So at this time, we're going to turn it over to Russell. Russell, thank you for agreeing, but also our parish nurse, Barbara, who served as our organist today. She's also going to come forward and offer a few comments. So Barbara, come forward, and then we'll turn it over to Russell.
Thank you, Pastor. Pastor asked me to give a few heart facts, because Russell's going to tell you what happens, what you do when things go bad with your heart, and how we can save each other's lives in here. But let's back up just a minute and see what we're talking about here. So, of course, Russell, we're talking about cardiac arrest. And just so we know, that's when the heart stops beating. There are over 20 million adults who have been affected by a cardiac arrest, a heart attack, myocardial infarction with that. In 2023, there were almost 95,000 deaths in our country from that, so it still is a problem with that. Overall, the trends for most of us in church here have been declining. But for some of you younger folks, actually, the hospitalizations have risen for some heart problems with younger folks. We can talk about that more later on with that. So let's briefly about risk factors: high blood pressure, diabetes, obesity, elevated LDL. I'm going to say a few words about that. Smoking, of course, diet, all that remains contributing to that. So when we talk about diet and these risk factors, one of the things that many of us probably here deal with is cholesterol, right? So what exactly is cholesterol? It's a fat-like substance, and we need it to build cells, to build hormones, both estrogen and testosterone. So cholesterol isn't bad. It also helps make vitamin D. And actually, our liver produces all the cholesterol that we need, but we also get cholesterol derived from foods derived from animals. So cholesterol does not dissolve in the blood. It travels through the bloodstream. And that's what happens. It is packaged in particles that we call lipoproteins. But the reason I want you to know about that, because many people here I know have high cholesterol levels, including myself. Let's talk, how do you know if you do? What are those two things to remember? The low density lipoproteins, we call them bad cholesterol. So LDL is the bad cholesterol. It carries cholesterol from the liver to the rest of the body. When there's too much LDL, it can deposit cholesterol in the walls of your arteries, which plugs up arteries, which causes your heart to stop, and then Russell will, if he's around, he'll save you. But if Russell's not around, you got a problem. So you should know what your LDL is, and you want your LDL to be less than 100, okay? Less than 100, so remember that number with your LDL. Now there's what's called good cholesterol, and this helps remove excess cholesterol from the bloodstream and carries it back to the liver. So for the good, that high density lipoprotein, you want that to be over 60. Okay, so the good you want it to be over 60, the bad you want it to be over 100. We can say a lot more with that, but that's all you're going to get on that. The one last thing I've also been asked to talk about is atrial fibrillation. And more people are being diagnosed with that, including JR and myself. Atrial fibrillation is a common, irregular, and rapid heartbeat. It's when the heart's upper chambers, the atria, are quivering instead of firmly pushing that blood out like it was supposed to be contracted correctly. When you have this fibrillation, you can feel it sometimes you cannot. After I was supposed to play for Pentecost, I was in the emergency room with atrial fib. That's when I got diagnosed with mine. Jerry's had his for several years with that. So you can sometimes feel the palpitation, sometimes you cannot. You can also have fatigue and dizziness, shortness of breath. The risk factors of that, again, are the same. High blood pressure, this coronary artery disease with the cholesterol building up with that, obesity, diabetes. But what I found out when I had this diagnosed, also caffeine can aggravate it, as can alcohol. And smoking, of course, is bad for everything across the board with that. Alcohol in some moderate. Actually, now we're saying any alcohol is not good. And of course, we should all be eating healthy diets if we've done the conversation. But when mine was diagnosed, I was so surprised because I tried to eat healthy. I've never taken a puff of a cigarette. I limit how much alcohol I have. All I have is a chai on occasion, coffee. So I was so upset with the cardiologist, and I exercise every day. I rarely take a day off from exercising. And he said, well, Barbara, the reason why is you're old. And yes, I reached my 10 plus. But so I'm exercising every day, so that's part of the problem. But you don't want to quit exercise. That was very surprising to me. It says just like your knee, or Lindsey Vonn, none of us are as bad as Lindsey Vonn is this morning, but just like if you've been running exercise all your life, your knees are going to give out. Is Belief is the leading electrophysiologist in the state. Darren and I both see Dr. Sean Mazer. So from exercise all the time, your heart will develop some atrial fib. It helps to monitor it on your watch or something. Don't stop exercising, keep doing it, just be aware of it. So just want to kind of give you this background information. Be happy to go into more detail with any of that. But if you're eating bad stuff, the cholesterol's plugging up your bloodstreams, and your heart's going to stop, Russell's going to save you and show us what to do. Thank you, Russell.
Thank you, Barbara. Just a second. I just got that. Can you give him your mic?
Yes, I can.
That would be great. Oh, be mic'd? Be mic'd, yes. I apologize. I had to leave during the service because my daughter's car ran out of gas on the interstate coming off of the St. Francis exit. And so I got the gas off my hands. I had to also jump her car. So I'm glad I could give you time to get him mic'd up. So this will all work. Road service.
I think something like that?
Yes.
Yep, all right. All right, thank you everybody. Those that don't know me, I'm Russell LeFevre. I sit with the LeFevre clan here. I've been a nurse for about 15 years now. Had some previous EMS experience prior to that. Most of my career, I worked on medical surgical units, the emergency department, was a house supervisor, was a flight nurse, and most recently is a manager of an emergency department. Most of my time has been in the emergency department. What we're going to talk about today is what we call hands-only CPR. Prior to this, so I do teach BLS. I teach a basic life support instructor, an advanced life support instructor, pediatric advanced life support instructor, trauma nursing core course instructor, and an emergency nursing core course instructor. So a full BLS class takes about 4 hours. We're going to condense this down into just the latest literature, which is just from the American Heart Association, which is just hands-only CPR. And so one thing I want to point out, we're also going to cover our AED machine. This is the automated external defibrillator machine, and it lives in this white cabinet back there by Barbara, hanging on the wall. And so why this machine is important and why we stress hands-only CPR is early CPR, good high-quality CPR by bystanders on scene really improves somebody's survivability rate. If there was no CPR done on scene, they really have a dramatically less of a chance of surviving that cardiac event. So early and good high-quality CPR plus early defibrillation can improve somebody's chances of survival up to 4 times. So pretty significant. That's why we stress early CPR and early defibrillation. And we see this pretty often in the emergency department when patients come in and there just wasn't any CPR being done on scene for quite some time, and it does make a difference versus those who were doing CPR on scene. So as Barbara mentioned, there may be a lot of reasons why somebody collapses. And so we're going to walk through a bit of an algorithm here. So if you're at Walmart, you're in church, and somebody's, sitting in the pew, and they fall over, or they're walking, right? You're walking with your buddy down the street, and all of a sudden they collapse. What we want to do is first get them onto a hard surface, so get them out of the pew, lie them on the floor. You want something hard underneath them. If they're sitting up in a chair, get them out of the pew, get them in the middle of the aisle here, get them lying on a flat, hard surface. And then the first thing we're going to do is just tap and shout. They may have just passed out because they have low blood pressure, they may have passed out because they have low blood sugar, they may have had a seizure. And so the first thing we're going to do is just check them. Tap and shout. Annie, are you okay? And we're looking for any responsiveness. If they are unresponsive, then we're going to move to the next step. And now this is sometimes a step that we miss the most, but it's probably one of the most critical. Call 911, right? You don't want to do this by yourself. I don't want to do this by myself. We want the paramedics. We want paramedics on the way with the drugs, with the shocky machines, with all the things, right? Call 911. So tap and shout. Annie, are you okay? There's no responsiveness. Brianna, call 911. And that's important because when you're in a chaotic scene, you don't want to just yell out into the atmosphere, somebody call 911. Because when it's nobody's job, when it's everybody's job, it's nobody's job, right? And so it's better to just point, call 911, call 911. And that gives a directive to somebody to go call 911. Of course, if you're by yourself, you want to stop, just call 911 at that point. And they're really helpful because they'll just help walk you through. Is the patient on a hard, flat surface? Put them on a hard, flat surface. Tap and shout. Is there any responsiveness? No, there's no responsiveness. Then what we're going to do is look for a pulse. So we're going to check here what we call a central pulse, and this is called your carotid pulse. And it's just, kind of between the trachea and the back of your neck here in that little soft spot. Sometimes it can take a little bit. Everybody's neck is different, right? So just, check on your kids, check on yourself, and get used to finding that carotid pulse. We're only going to spend about 10 seconds finding that pulse and looking for breathing. That's it. That's all you get, 10 seconds. Checking for a pulse, looking for breathing. If there is no pulse or no normal breathing, called just regular breathing, right? The kind of breathing, agonal type of breathing, which is like, that's not normal breathing. So if there's no normal breathing and no pulse, then we're going to start CPR. And in preparation for our machine, ideally we go ahead and have the patient undressed, but we'll talk a little bit more about that in a second once we get to the AED. And so what we're looking for is right in the center of the sternum, kind of across the nipple line, and we're going to put our palms of our hands right there in the center of the chest. We don't want to be too high up on the neck, and we don't want to be too low on the stomach, right kind of center of the chest. With our arms nice and locked, using our own body weight, we'll start CPR, compressing the chest about 2 inches or about 1/3 the diameter of the anterior posterior chest. Then we're going to compress it about a rate of 100 to 120 beats per minute. And at this point, we're just going to be kind of continuous. So I got my little metronome here so we can hear kind of what that sounds like. This is 110 beats per minute. It's also the same rhythm of staying alive.
Yeah.
Staying alive, staying
Play it for a
alive.
post.
You don't want to stop and boogie, right? Stay focused. You guys can dance later, that's right. Okay, so we'll go back through the steps. Somebody passes out. We get them down on the floor. Annie, are you okay? Unresponsive. There is no responsiveness. Call 911. We're going to check for a pulse. We're looking for any spontaneous breathing. And we don't feel a pulse, and we don't see any breathing. And we're going to start CPR. Now, at this call 911 phase, it's probably a good time to also request the AED. If somebody's thinking about it and say, oh, we need the AED, but it's also a good time to request that. So tap, shout, checking for a pulse, looking for breathing. No, call 911 and grab the AED. So now the AED arrives. Somebody's already starting CPR. AED arrives, and we're going to take it out of its case. You'll notice there's a few things inside the package here. We've got a pair of scissors, and so we want to expose the chest. So we're going to stop CPR while we cut the shirt off. Shirt, bra, everything's got to come off. We're going to expose the chest because we're going to want to put these pads on skin to skin. The pads have a, we'll go ahead and turn it on.
Adult pads.
Have a placement indicator. So
In case of emergency,
one's going to go over the chest,
the green on-off button.
and one's going to go here under the armpit. Now, depending if you're male or female, we're going to want to lift the breast tissue up and out of the way to put that pad good and under the skin. You don't want it on the breast tissue. The shorter the distance the electricity has to travel through the skin, through the muscle to reach your heart muscle, the better. So that's why we want it on the bony aspect underneath your armpit, we call the axilla, versus on the breast tissue, male and female. So up under there, move the breast tissue out of the way, place that pad there, the other pad's going to go here, just as the picture indicates here. Then we're going to pull this down. This is going to uncover.
By removing all clothing from the patient's chest. Cut clothing if needed.
Scissors. Okay. And then we're gonna, I don't know, do we have another set of pads?
When patient's chest is bare,
I don't know, do you want me to open
protective
these?
cover and take out white adhesive pads.
So it's walking me through step by step what to do. Peel this off, take out the pads.
Look carefully at the pictures on the white adhesive pads. Peel one pad from the yellow plastic liner.
So this
Place
one,
pad exactly as shown in the picture. Press firmly to patient's bare skin. When the first
And the
pad is
other
in
one here.
place, look carefully at the picture on the second pad. Peel the second pad from the yellow plastic liner. Place pad exactly as shown in the picture. Press firmly to patient's bare skin.
Pretty high up in the armpit.
right up under there.
The left side.
Mm-hmm.
When the first pad is in place, look carefully at the picture on the second pad. Peel the second pad from the yellow plastic liner. Place pad exactly as shown in the picture. Press firmly to patient's bare skin. Press pads firmly to patient's bare skin. Make sure that the yellow plastic liner is completely removed from both pads. Place pad exactly as shown in the picture. Pads must not be touching clothing or each other.
I think right now it's trying to detect a rhythm.
Press pads
And so it's repeating me to make sure that the pads are attached. But once the pads are, don't try this at home. This is only for demonstration purposes only. Okay,
Analyzing.
so now it's going to analyze the rhythm.
No one should touch the patient. Shock not advised.
So, all right.
Touch the patient.
So,
Check airway.
is it?
Check breathing.
So what it's detecting. I'm going to go ahead and turn this off.
CPR. For help.
So what it's detecting is that I have a normal heart rhythm right now. If it's detecting an abnormal rhythm, it's going to give you the shock advised. When it gives you that shock advised, this little yellow button with the lightning bolt on it is going to light up. And it's going to tell you to stop CPR, to clear the patient, nobody touch the patient, deliver the shock. Once you deliver the shock, it's going to go into a metronome, back into that metronome count. And then it'll actually count for you. You're going to do 2 minutes of CPR, and then it's going to tell you to stop again. And it's going to reanalyze the patient's rhythm and tell you either shock is advised or the shock isn't advised. And it'll just keep doing that until help arrives. So until, either you shock the patient out of the rhythm and it'll say there's no shock advised, where the patient starts waking up, which is not uncommon to start doing CPR and the patient starts waking up. So never feel bad about, the patient falls down, Annie, are you okay? They're unresponsive. You check for a pulse and you're like, I don't think I feel anything. I don't see any breathing. I'm going to start CPR. Never feel bad about starting CPR. Patients will wake up and they'll tell you when to stop. They'll tell you, stop, please. Because what's the alternative? They stay dead, right? So never feel bad about it. Just, you know what? When in doubt, CPR it out. Like, just start pumping on the chest. And if they say, okay, let's stop. Let's reanalyze, check a pulse, look for normal breathing. And sometimes that's just how that cycle runs. It's 2 minutes of CPR, stop and analyze for a rhythm. Nothing's changed, 2 minutes of CPR. Stop and analyze the rhythm. Or it's CPR shock, and that can go on for quite some time. And sometimes they just wake up from it with a couple of rounds. So that's kind of the AED in a nutshell. It's pretty simple. It'll walk you through step by step. You pull the pads off, place them on the chest, analyzing. As you can see, it takes some time for it to kind of walk through the steps. So we recommend, like the tap, shout, check for a pulse. There is no pulse, no normal breathing. Go ahead and call for help, call 911, grab the AED, start CPR, and then have somebody else unpacking the machine, putting the pads on, and you really just want to keep CPR going until the machine tells you to stop. Don't touch the patient so it can analyze for a pulse. Why that's important is it's your cerebral and your cardiac perfusion pressures that really perfuse your core organs. So as long as your heart's pumping, you're getting pressure to all your core organs. As soon as the heart stops, that pressure just starts to plummet. And it's that pressure that we want to keep going by pumping the heart. And so it's critical to maintain that coronary perfusion pressure as much as possible. As soon as that pressure drops, that's when brain damage happens, when core organ damage happens, if that perfusion pressure stays too low for too long. So early CPR and good high quality CPR is really life-saving. And then of course early defibrillation, but that CPR is really critical. And then hopefully help arrives, right? CPR can be quite exhausting, so always good to have somebody ready. And even teenagers, even young kids, studies have shown, can perform high quality CPR. It's just locking your hands and using your own body weight to push on the chest. So we've had even young kids as young as 10 performing CPR and have been quite successful at it. What else? You are covered under the Good Samaritan law, so if somebody should pass out at Walmart and maybe they're DNR, DNI, we don't know, right? They've got advanced directives. If you are inclined to go ahead and start CPR, you are covered under the law. It's called the Good Samaritan law, to where, should somebody question your motive there, you are protected by that. What else, Barbara? Any other questions?
Excellent job.
If the person's on the floor, you can't really stand up and do it, can you? You have to get on your knees.
Oh yeah, no, this would all be, good point, this would all be taking place, on the floor. So, like this. Yeah. And so it's just high quality continuous CPR is really the goal. We used to do 30 to 2. You do 30 compressions and you stop and give 2 breaths. They're saying now they're less inclined or motivated to do CPR given the fact that they don't want to do mouth to mouth. So they went away from that. Don't worry about the breaths. Just focus on high quality CPR. Your body's got quite a bit of oxygen still in its blood that you can circulate around, and even doing CPR kind of forces the chest to inhale and exhale somewhat. So it'll pump that oxygen around for a while, which is way better than just no CPR at all. So good high quality CPR. I like to put this dummy on the table just outside the door, and as you walk out, just give a couple of compressions just to see what it feels like to press the sternum down a couple of inches. It takes a little bit, but it's not terribly difficult. And if you hear some cracking and crunching on the chest where you're doing it, it's normal. You're usually not breaking bones. You're just busting that calcium and kind of spreeing up that cartilage that's been a little calcified. Sometimes you are breaking some bones, but it's okay. It's better. We can fix a broken rib, but you can't fix a dead person. So.
Any other quick questions for Russell? Russell, thank you.
All right, thank you very much.
Once again, our AED machine is back in the alcove there. It's in a white box AED, and it's for anyone that can use that. That's right. I mean, it's not just you, Russell, or Barbara. It's anybody can do that, and we're all encouraged to.
They do offer BLS classes at the community college. I don't know if there's really any age requirement. Renee just went and got her BLS certificate, so if you're interested in taking the full course, the Santa Fe Community College offers those classes.
Right, well, I know our preschool staff, they have to go through all of that too, and so Laura's aware of that too. So, any other final questions? Well, thank you again, Russell, for that. Thank you. We do this once a year, usually in February,